Hi, my name is Jared Young, and I'm going to present a risk assessment for waterborne E. coli in rural Cambodia. Approximately 24% of the global disease burden and 23% of all deaths are attributed to the environment. Of these, diarrhea is one of the greatest, with over 1.5 million deaths annually. The main causes of diarrhea are microorganisms, including pathogenic E. coli. There are numerous mechanisms after ingestion that E. coli can induce diarrhea, but the actual amount required to cause disease is difficult to quantify. Though several methods of control have been attempted for this hazard, it is difficult to interrupt the pathogenic cycle. Thus, effective interventions are required and should be aimed at the academic research field, Cambodia's water policy, as well as Cambodia's population. Cambodia is a developing nation which has been rated 138th out of 187 countries on the Human Development Index, making it one of the least developed nations. In the 1970s, it experienced violent internal conflict, destroying much of its physical infrastructure and a quarter of its population. As a result, many of the factors which contribute to good public health are lacking, including safe drinking water. In Cambodia, diarrhea accounts for most of their environmental disease burden, with 27 DALYs per 1,000 people and a death rate of over 2,000 per year. Quantifying risks. In general, there are three ways of estimating the risk, and this includes epidemiological studies, quantitative risk assessments, and qualitative risk assessments. Though I looked, there are no epidemiological studies examining waterborne E. coli in Cambodia. The second method of risk assessment is through quantitative microbial risk assessment, or QMRA. The process of QMRA will appear familiar to us as it incorporates hazard identification, exposure assessment, dose-response modeling, and risk characterization. Hazard identification. There are three main types of microorganisms found in drinking water: bacteria, viruses, and protozoa. Of these, pathogenic E. coli has been identified as the most frequent cause of chronic diarrhea worldwide and acute diarrhea in Cambodia. Although they are part of the natural fecal flora, some strains can cause intestinal disease, such as diarrhea, and even lead to death. Mechanism of action. The basic mechanism of action underlying all diarrhea is incomplete absorption of water from the intestinal lumen through either secretion or osmotic retention. Secretory diarrhea occurs when pathogens produce toxins inhibiting absorption and causing fluxes of fluid and electrolytes into the small intestine. Osmotic diarrhea occurs when unabsorbed nutrients, especially carbohydrates, cause an osmotic gradient, drawing water into the intestine. Here, diarrhea is exacerbated by consuming any osmotically active substance, even breast milk. Additionally, small-chain fatty acids produced by bacteria are important, as they are also osmotically active. Exposure assessment, sources of water. The first component of exposure assessment is the examination of water sources in rural Cambodia. Here, water is abundantly available, with several large rivers and lakes spanning the country. Groundwater is also widely available and can be accessed through wells and machine-dug reservoirs. More advanced drilled wells with accompanying hand pumps have also been supplied through donor organizations such as UNICEF. Unfortunately, most of the sources are heavily contaminated with fecal coliforms and pathogenic E. coli. On this slide, I have shown you some of the data on E. coli concentrations in various wells in rural Cambodia, but I want you to understand that E. coli concentrations, even in the Ottawa River in Canada, are only 86 per 100 ml. But one study conducted in Kep province demonstrated that almost all environmental sources of water were contaminated. These included open pit wells and reservoirs. Even studies that looked at E. coli in surface water, looking at lakes and rivers, demonstrated high amounts of E. coli, where 15% of the water samples had more than 1,000 colonies per 100 ml. Hazard quantification. The next step in exposure assessment is the estimation of the number of microorganisms ingested. Unfortunately, this prediction often involves some subjectivity. This is because not every glass of water will have the same amount of bacteria, nor is it possible to directly measure the concentration in every drink. Thus, measurement is often carried out at the source of water, such as wells, ponds, and streams. The other component of exposure assessment is the volume of unboiled water consumed. This again can be a variable. Finally, the daily exposure to pathogens is found by multiplying the concentration of the pathogen by the volume of drinking water consumed. This is the dose of pathogenic E. coli. Dose response. The next step in QMRA is the dose response risk assessment. This would involve the probability of diarrhea following an exposure to E. coli as derived from particular dose-response models. Though some dose-response data has been obtained using healthy adult volunteers, it is likely inadequate for use in vulnerable populations such as children. In general, well-dispersed pathogens in water are considered to be Poisson distributed. when individual probability of any organism surviving and starting infection is the same, the dose-response relationship simplifies to an exponential function. As can be seen by various dose-response graphs, low exposures on the dose-response model is approximately linear and can be represented as the probability of infection resulting from a single organism exposure. Risk characterization. The aim of risk characterization is to integrate information from exposure and dose response to express public health concerns and outcomes. Here, complex statistics are used to examine many variables not represented in a simple dose-response relationship. Thus, various models have included formulas that statistically represent host defense mechanisms which decrease the bioavailable dose of pathogens. These formulae also help represent multiple ingestions which may have a synergistic effect and increase the likelihood of illness over time. The next step is combining risk of illness with epidemiological information to express the data in a meaningful way. At the present, the World Health Organization recommends disability-adjusted life years, or DALYs, as a metric for translating the risk of disease burden and general health burden per case of illness. But unfortunately, QMRA is a new and specialized field, thus its methods are still being developed, and the expertise and resources required to conduct QMRA risk assessments are not widely available. In fact, I conducted an exhaustive search of the primary and secondary literature for QMRA and E. coli, but very little information was found other than dose-response relationships. As a result, I could not complete a QMRA assessment. Qualitative risk assessment. Qualitative risk assessments are commonly used for screening risks to determine whether they merit further investigation. Although hazard identification and exposure hazard are common to qualitative and quantitative methods, dose-response models and risk characterization steps are usually replaced with risk rankings. These rankings are generally derived from expert opinion. The advantage of this approach is that the process itself often presents solutions to minimize risk. For example, if the risk of infection is high due to animal feces entering the water, then the solution will become clear. It is to decrease the feces from entering the water. But on the other hand, expert opinion does not always produce the correct answer, as experts' opinions can be subject to bias and inaccuracies. If I were to conduct a qualitative risk assessment for pathogenic E. coli in water, it could be relatively straightforward. Since the likelihood of exposure to E. coli is likely once per day, it is considered almost certain. And since the impact occurs on a public health level, the severity is defined as catastrophic. Water policies and regulations in Cambodia. In Cambodia, water policy has been set by the Ministry of Industry, Mines and Energy, who published the 2004 Drinking Water Quality Standards. These dictate the minimum requirements for all sources of water in Cambodia. These standards are represented in tables which dictate maximum acceptable concentrations, or MACs, for several different chemical contaminants and microorganisms. The MAC for E. coli and coliforms were listed as 0 colonies per 100 ml. Though construction of water supply and sanitation facilities has been ongoing in Cambodia, concentration has been in the urban settings. But in the year 2000, the United Nations began an international project which set a series of public health-related targets deemed the Millennium Development Goals. Based on these, Cambodian water policies are aimed at increasing access to safe drinking water to 50% of the rural population by 2015. As a result, numerous NGOs and international organizations have collaborated on the implementation of water and sanitation projects. Risk management. To this point, the control of waterborne E. coli in rural Cambodia has transitioned from boiling water to drilled wells and now point-of-use water treatment. Though boiling water is an effective way to destroy waterborne E. coli, it is problematic as the family is limited by the size of their largest cooking container. There is also the issue of recontamination of boiled water during storage. The use of machine-dug wells has also been an improvement, but research has shown that even these water supplies are subject to fecal contamination. The next alternative is household point-of-use water treatment. Here, a house-based water filtration system is used to remove microorganisms. There is evidence that these filters can be effective in preventing diarrhea, but systemic reviews have yet to prove this. My recommendations. Research directions. Although the World Health Organization and the research community heavily emphasizes QMRA, this approach is too nascent for developing nations. While pathogenic E. coli has been recognized as one of the largest causes of diarrhea worldwide, it is still not very well quantified. In fact, almost all published QMRA studies examine Campylobacter, Cryptosporidium, and rotavirus. Thus, more models are needed to be designed for data points to be generated for E. coli. Another weakness of QMRA is its applicability for health policy planning within developing countries. Even if enough data points were available, they would only be useful for populations where concentrations of pathogens are constant and the water is distributed equally among the population. This would only occur when the population already had access to water treatment systems. This is, of course, not the case for developing nations. As a result, the priority should be placed on better epidemiological data. Emphasis should be placed on recording both primary causes of death, but also disease burden caused by diarrhea. With ongoing data capture, Cambodia will be better able to tailor water policy to the needs of their populations. One emerging method of doing this is the verbal autopsy. Verbal autopsies are a research method that helps determine probable causes of death when there was no medical record or formal medical attention given. Here, non-medical field workers collect data which is used to later predict the cause of death. This is starting to be applied in several developing nations such as India and Vietnam. Water policy. At the present, the national standards for drinking water quality are outdated and provide only groups of tables which establish water treatment targets. But there are several problems with this approach. First of all, provision of MAC levels demonstrates the endpoint for treated drinking water. However, there is no guidance for the reader as to how to reach this endpoint. Furthermore, many rural communities lack the ability to purify their water, and most testing of MACs are done by international research bodies, NGOs, or private companies. Instead, drinking water policy needs to be a larger document that includes both risk assessment as well as the knowledge needed for using water purification technologies. When one examines the World Health Organization's guideline for drinking water quality, they will notice that the MAC levels are there, but there is a much larger emphasis on the process of risk assessment. Thus, a broad set of descriptive guidelines would allow communities to identify their own particular hazards and thereby tailor them to meet their specific needs. Secondly, water policy in Cambodia needs to place emphasis on the proficiency in education with current water treatment technologies. When one examines waterborne pathogen outbreaks in modern societies such as Waterborne and Canada, they will see that these outbreaks occur due to lack of education and proficiency with modern treatment methods. This could be the reason that point-of-use water treatment has failed to demonstrate an overall benefit in Cambodia. Public health education. Public health education is also an integral aspect of decreasing the risk of diarrhea from contaminated water. As indicated in prior studies, a 10% drop in vigilance nullifies the protective effects of point-of-use water treatment. As a result, investment must be made to modify individual behaviors so as to increase their vigilance. However, a better understanding of who to target must be accomplished through research. This is because health education to improve hygiene behaviors has proven to be difficult. Furthermore, effective public health education must also occur to address hygiene at a community level. As noted before, open defecation and the failure to confine excreta are primary factors that contribute to the cause of water contamination. However, the provision of toilets alone is not enough to decrease the rates of open defecation. To address this, community-level education has been implemented successfully in Southern Asia. Community-led total sanitation projects are based on the principle of triggering collective behavior change. Here, communities are facilitated to take collective action to adopt hygienic sanitation behaviors, such as using latrines instead of open defecation. Though this approach has been introduced in rural Cambodia, it has yet to be universally applied.